adrenal gland, which sits on top of the kidneys. It's called the adrenal medulla. It has different zones, or here they're showing, right? Zona reticularis, fascicularta, and glomerulosa. And they secrete basically different things based on the zones. So here we see, right, zona glomerulosa is secreting mineral corticoids like aldosterone. We're going to talk about this one in extensive amount when we talk about the renal chapter. This is one of the hormones which is also responsible for blood pressure regulation. Why? Because it acts on the kidney to reabsorb salt and water, right? So we're going to talk about that. Zona fascicularta, we see secretion of cortisol. This is your counter-regulatory hormone we just talked about, right? Which there were a couple of them, right? Epinephrine was the counter-regulatory hormone, with growth hormone, with glucagon, and we had cortisol. So these are your like stress hormones. They're secreted, right, when the body is under that effect of perceived stress or perceived status of, let's say, hypoglycemia, and these hormones will be secreted. DHEA, right? This is responsible for formation of some of the androgens, right? And then as you go down, right, especially the medulla, that's what we talked about, the adrenal medulla, it secretes epinephrine. So this, well, let me ask you this. How is this different from norepinephrine? How does epinephrine differ from norepinephrine?
Is released from the adrenal medulla from over in the kidney, in the top of the kidney.
Okay, and how is this different?
As I remember that the norepinephrine that goes to one oxidation state from epinephrine. That's what I said.
But where is it? So what you said is correct from the standpoint, right? This epinephrine is released from adrenal medulla, right? So this epinephrine is released from adrenal medulla and it goes into your blood, right? So this goes into your, circulation, goes into your blood.
Part of the epinephrine transfer to norepinephrine by some kind of enzyme. I don't remember how it is right now.
So it's not per se the enzyme. So this one is a neurotransmitter. So this norepinephrine I'm referring to, this is a neurotransmitter, right? And the major difference is this, right? This is usually released at the synaptic vesicles, right? We learn about norepinephrine release from the nerves to target specific receptors, like let's say beta 1, right, or alpha 1. So you could have a response from the neurotransmitter, which is much faster response, and then you have epinephrine, right, which is secreted by the adrenal medulla, goes through the blood. This is your endocrine response. Endocrine meaning it's carried via blood, and then it's going to exert its effect systemically, where it reaches its target receptor sites. So the difference is one is basically a neurotransmitter. It's a faster response. The other one is carried in the blood, slow response. This is the major distinction here, right? This is just another picture showing you the same zones and what they secrete, right? The one you want to be familiar with for this lecture would be the medulla, which secretes epinephrine, and then what you want to be also familiar with going forward, right, is the aldosterone. Aldosterone secreted by the top zone, zona glomerulosa, and the aldosterone is going to be responsible for your blood pressure regulation. Right, because it acts to reabsorb salt plus water. So we'll talk about in the renal chapter how that works. Okay. Here, right, just to go back into the sympathetic nervous system, right, and the receptors that we talked about and the ones you want to be familiar with, right, the effects of epinephrine and norepinephrine, right. Let me see you guys if you still remember. Let's say epinephrine response on a beta 1 cell. What is it going to do?
Stimulate the heart.
Stimulate the heart. How will it stimulate the heart?
Force the contraction.
Right. First, force the contraction. So increase the contraction, increase the heart rate, right? So a chronotropy, dromotropy, and inotropy, and the strength of the contraction. So that's what's going to do. What about alpha beta 2?
The lungs.
What specifically about the lungs?
Vasodilatation of the lung.
Vasodilation.
Yeah,
Probably that's what I mean.
bronchodilate.
Yeah, yeah.
Bronchodilate, right? If we talk about, let's say, beta 2 on the uterus, and we give, let's say, medication like retinidine, which is a beta 2 stimulator, it's gonna relax the uterus, right? Then we talked about alpha 1. What does alpha 1 do?
Vasodilatation of the blood vessel, peripheral blood vessels.
Is it vasodilation, alpha 1?
Vasoconstriction.
Vasoconstriction, right? So vasoconstriction by pressure response, right? And then we talked about today alpha 2, right? Alpha 2 was essentially norepinephrine acting on itself to basically stop further release of epinephrine, like via the G inhibitory pathway, right? So it basically stops the further outflow, right? So it's an inhibitory signal. So this is what we learned about, right? So these are the sympathetic responses for the adrenal medulla, which is one of the organs in your endocrine system, right? And here, right, is essentially shows you the receptors and the functions, right? So everything you basically just talked about. If we start right with beta 1, right, it was the stimulatory response, right? G stimulatory, increase the heart rate, contractility, right? That's one you talked about. Beta 2, we said, was vasodilation, bronchodilation. And we talked about alpha 1 was increase smooth muscle contraction or increase systemic vascular resistance. And then alpha 2, this was the inhibitory response, G inhibitory. It reduces the outflow, right? So it reduces this response. We also see when you stimulate the alpha 2 receptors for the insulin, right? This shows you reduce insulin release. So this was the setting of diabetic ketoacidosis, right? Remember we talked about diabetic ketosis. So let me go back and show you. So here you see alpha 2 response, right? Which is done by sympathetic nervous system, and it causes reduction of insulin release. So let's go back here and we'll see how that causes. Remember I said in diabetic ketoacidosis, one of the reasons it can trigger it is fever, sepsis, trauma, surgery. So what do you think is secreted in these conditions? What is the fight or flight hormone?
Epinephrine.
Epinephrine, right? So if you have a fever, you will have fast heart rate. In sepsis, right, you will have fast heart rate, trauma, right? So you basically secreting epinephrine, right, or norepinephrine. So you have increased norepinephrine response. And if it works on the alpha 2 receptors, right, specifically on the beta cells, this is going to then reduce insulin release. You see how you have reduction of insulin release? So that's what's going to cause the compounding effect, right? So make sense? Imagine you were working as a ER tech, right? In a hospital, and you had a patient who is non-compliant with his medications. He is insulin-dependent diabetic, right? And he's not compliant. He doesn't take his insulin for whatever reasons, right? He eats junk food. He drinks soda, right? And he's not compliant at all with his medicine. So right before his appointment, right, and you're the one checking his sugar, right before his appointment, he takes his insulin, he takes his own glucometer, right, and he says, okay, my sugar now is 80 milligrams per deciliter, right? But every other day he's not compliant, right? Let's say every other day his sugar is 200 or maybe 240, right, in these ranges. But right before his appointment to see the doctor, or you know, his sugar is 80 milligrams per deciliter, and you're assessing this person, you check his sugar, it's 80 milligrams per deciliter. So did he fool you? Like, would you think he is compliant with his medications? He's fine?
Yeah.
So he fooled you, right? And how would you be able to tell him, well, no, you didn't fool me, you're non-compliant?
Well, If his blood sugars are always high, he would be he'd have symptoms at 80.
So let's say right now he doesn't show any symptoms. What I'm saying is to you, imagine you have the following situation. Quite often happens with young people, right? The doctor prescribed them insulin, but they eat junk food, right? They're not really adhering to any dietary regimen. They eat, let's say burgers, fries, drink some soda, right? Pepsi, Coca-Cola after eating all that. And normally their sugar, right? They take their drugs seldom, right? They take their insulin when their sugar is really high. And let's say on daily basis, right? Monday, Tuesday, Wednesday, Thursday, their sugar could range between 200, 240, right? 260. Then they take the insulin, maybe it's back to 180, right? So their sugar is definitely not in the normal range. But right before going to the doctor, right before going to the emergency room, let's say for whatever reason, they took enough insulin and they used their own glucometer to bring their sugar down to 80. You come in, right? Use your glucometer, check their sugar, it's 80, right? But every other day it's this, but today is this. So they fooled you? You'll think they're compliant?
No, they would have a high A1c.
Yeah. So what is that?
That's the measure of the blood sugars over the past 90 days.
Yeah. So can you elaborate more? So you're on the right track, but can you elaborate more? So yeah, he's saying this is A1c, but what is that?
It's
level of glucose.
Yeah. So your hemoglobin, right? That basically that's found in the red blood cells that transports oxygen, right? There is a portion of that hemoglobin that's called hemoglobin A1c, right? All of them together make 100% of your hemoglobin. This is called glycosylated hemoglobin. And your red blood cells roughly have a span of 120 days, right? That's how many days they live. So if over the 120 days, this is your sugar level, right? And the sugar binds to this hemoglobin, this level of sugar that's bound to the hemoglobin A1c will certainly be elevated. It's not going to be in the normal range. It's going to be elevated. Why? Because every day you are not compliant, right? But today you just, fooled everybody, right? So this is what they measure, right? They measure hemoglobin A1c. So they tells you because this glucose 6-phosphate will bind and it will show you increased amount of glycosylation. And because your red blood cells have a mean life of 120 days, right, this hemoglobin will hold on to that glycosylation, right? And if they test this in a diabetic, they'll see that. So they'll say, right, normal level is below 5.7%, and pre-diabetes is between 5.7 to 6.4. Anything above, right, is 6.5. How is this helpful for you? Let's say you go to a call, right, and you have someone who is, let's say, not really compliant, and you check their sugar. Let's say their sugar at that time may be 200, right? They may not be having like a medical emergency per se. And you want to ask them, right, when you went to your doctor, what was your hemoglobin A1c level? So if they tell you anything that is above this number, right, you definitely want to talk to them and say, let's get you evaluated, because if they're not compliant, this number can be, 9.5%. This could be even higher. It could be, over 10%. And it's a big problem, right? And those are the patients that may be going into your DKA, diabetic ketoacidosis. So you want to take them to the provider so the doctors can look at their medications and educate them, or maybe prescribe the medicines, right? So even though, right, you go to a call, your sugar may be 200 milligrams per deciliter. Patient says, I want to stay home. I don't want to go to the hospital, right? Ask them, what is your hemoglobin A1c? When was the last time they measured this, right? And if they tell you, right, oh, I did it like, 6 months ago and it was high, it was 7.5. You want to say, you know what, let's take you to the hospital. Let's evaluate this number, because this number is very high. Probably means they're not compliant with their regimens, right? And their daily sugar is very high. And this may send them into diabetic ketoacidosis. And that's a big problem. They may be ending up into the ICU, right? So you could basically prevent them being admitted to the intensive care unit. So advocate for your patients, right? Explain to them what this is, right? So this is just one of the example, right? Why they will have this. Any questions about this? So next portion, after talking about epinephrine, norepinephrine, and your insulin and glucagon, next we get to your, hypothalamus, right? Which is essentially the regulator, right? What controls the secretion of all this, right? But also we have your anterior and posterior, right? Pituitary gland. So here we see, right, the anterior lobe. Later we're gonna talk about the hormones it secretes. It secretes quite a few hormones. The posterior lobe of your pituitary secretes antidiuretic hormone and oxytocin, right? So if the hormone is called antidiuretic hormone, what do you think it does?
Retention of water.
Retention of
Water.
water. Excellent, right? Antidiuretic hormone. The forms that's going to be in your REMAC protocols, it's called vasopressin, right? Vasopressin. So vasopressin, the way it works is it basically binds to vasopressin receptors, and it doesn't allow your kidneys to basically release water. So it holds on to more water. Antidiuretic means it does not allow diuresis to occur. So in what conditions you may think may be beneficial to hold on to the water, not get rid of water?
They're
Diarrhea.
hypotensive.
What were you saying, John?
Hypotensive.
Hypotensive, excellent, right? So yeah, hypotension. And the other conditions we were also giving them in a setting of cardiac arrest. We were giving initially vasopressin in place of epinephrine, right? And for exact same reasons you're talking about, right? We want to maintain the blood pressure, and you don't want the body to basically be losing excess water. Also, we're giving in states of shock, right, to basically maintain blood pressure, right? So that's ADH, antidiuretic hormone, or vasopressin. OXT is oxytocin, right? Oxytocin is released by posterior pituitary. We used to, believe it or not, we used to have these medicines in our formulary, but then they removed it, right? What do you think this medication does, oxytocin?
It's a smooth muscle relaxer.
Is it a relaxer?
Oh no, it stimulates contractions of smooth muscles.
It was a contraction. So it was usually, we had this medicine, right, in the setting of postpartum hemorrhage, right? If after giving birth, the uterus was basically boggy, it was like floppy, right? The uterus didn't contract and it was bleeding excessively. You could have give oxytocin to basically cause constriction of the uterine muscles. In the setting of in the hospital setting, I should say, they use this to induce contraction. So if they give this medication very under control manner, they could cause spasms of the uterus, or contraction of the uterus, I should say, to basically induce labor, right? So in the hospital, it's given to induce labor. It also can be given in after post-labor, postpartum, to basically cause uterine contraction if there's excessive bleeding. You can also do, fundus massage to stimulate the uterus to contract. But both of these are secreted by the posterior pituitary gland, right? And that's their function. We're going to get into the anterior pituitary in a moment, right? So this was just to show you the posterior pituitary was secreting antidiuretic hormone, acts on the kidneys. The oxytocin is usually made in the uterus. Main function, right? Uterine contraction. It also causes bonding with the neonate that's born, right? And also, if you give the mother upon delivery the neonate to nurse, right? And the mother allows the neonate to nurse, this will also stimulate oxytocin release, right? And oxytocin release is good because it's going to stimulate contraction of the uterus, maybe help you with placenta delivery. It's going to allow bonding, right, with the neonate, and contraction of the uterus to maybe, if there was any bleeding, to basically cause that uterus to contract to stop the bleeding. Right, so we talked about this in terms of your anterior, right? Anterior lobe, it has quite a few functions. One of it is thyroid stimulating hormone. So thyroid gland, right? Usually, right, for metabolism, we see this, right, stimulation. we see adrenocorticotropic hormone. So this stimulates the adrenal glands, right? We already talked about the medulla, adrenal medulla, right? Secreting your epinephrine. We talked about adrenal cortex secreting your cortisol. You also have your glucotropic hormones. So this is under this function. FSH, LH, right? We see this in ovary and testes, luteinizing hormone for testosterone production. We see follicular stimulating hormone for the follicle maturation, especially when you're talking about the female cycle, right? And these hormones play a role there. Growth hormone, you see this as, bone formation, muscle growth, but also it plays a role as a counter-regulatory hormone in the response, right, of, we saw when your sugar is low, hypoglycemic state, right? Prolactin production and melanocytes. So this is secreting for melanin production. So this is part of your anterior lobe of the pituitary. This is the part of your posterior lobe of your pituitary. This is just a bigger picture. Another thing you may see, right? Sometimes they may write for the testing purposes. They will write neurohypothesis. So this basically is another name for posterior lobe. And then adenohypophysis is another name for the anterior lobe. So these names may be used interchangeably, right, in the testing, so that you know. So if you see this name, this basically means posterior lobe. You see this name, it means the anterior lobe. This is just close-up view, right, of the hormone secreted by the anterior pituitary lobe, right, and the target cells that they control. And this was from the posterior pituitary lobe and the target they control. The reason I would say focusing on this is because we had medications that we used to administer. We're still going to give this medicine, vasopressin. We no longer give oxytocin, but any of you guys who are going to the hospital, right, especially if you're doing any rotations in L&D, you will see this drip, right, being administered so that you know its responses, right? It can induce labor, and it also is given postpartum for postpartum hemorrhage. And here is basically, right, all of them combined into one diagram, right, to show you the hormones that are secreted, the target tissues, right, and the response. And I think we talked about all of these here. Yeah, we talked about all of these here. So just to show you an example, right, how the direct control from the nervous system. So from here, you will see, right, the stimulation from the anterior pituitary, right? It's going to come stimulate the adrenal medulla, right? And you will see the secretion, right, of the epinephrine, which we talked about, which is the endocrine hormone circulates in the blood, right? And the effects it exerts on the alpha beta cells, right, in the body. And this shows you just anterior side of it, and this is the posterior side of it. Okay. So next, we're going to go to the thyroid hormone, and specifically what I want to focus here, right, is the thyroid and the parathyroid. The thyroid is this gland, and the parathyroid is basically found on the gland itself. And this is what basically controls our calcium level in our body, right? So this shows you just microscopic views of both of these glands. This is a close-up picture of the thyroid gland and the parathyroid, which are found on the thyroid, right? Just a close-up views of the cells. And here we get to the point, right, of the calcium level, right? Normal level, here they give you 9.5 to 11 milligrams per deciliter. Remember, in the other lecture, I said 11 milligrams per deciliter. Just the easy way to remember. If you remember 911, right? If you call 911, that's a normal level, 9 to 11 milligrams per deciliter. So let's see what happens is when blood calcium levels are increasing. So high calcium levels. Anyone know what is the term for high calcium levels?
Hypercalcemia.
hypercalcemia, right? So anything above 11 milligrams per deciliter is hypercalcemia. So what happens is your thyroid gland, right, is going to secrete something known as calcitonin. And the purpose of calcitonin is when you have high amounts of calcium is basically to uptake the calcium. So it's removed, right? It's absorption from the digestive tract. And it's also excretion from the kidneys. So increased secretion by the kidneys. Both of these functions are going to basically decrease your calcium to the normal range, right? Another time you may have low calcium levels, right? Hypocalcemia. And what happens is in that setting, your parathyroid glands, these cells here, will secrete parathyroid hormone, PTH. And the purpose of this is basically, it could be twofold, right? One is to work on the bones, right? And the bones will basically resorb and they will secrete the calcium storage, right? It also increases reabsorption on the kidneys. So instead of moving calcium into the urine, it's going to reabsorb from the proximal convoluted tubule. It's going to reabsorb the calcium, right? The resorption of the bone. So the bone stores are resorbed. Calcium is coming into the bloodstream. And then by the kidneys, right, you also have increased calcitrol. And this further allows calcium reabsorption by the GI tract. So this is basically two opposing sides of the calcium, right? When you have too much calcium, thyroid gland secretes calcitonin. When you have too little calcium, parathyroid secretes parathyroid hormone, right? I don't know if you recall in the cardiac chapter, I said sometimes you may have a patient with cardiac dysrhythmia, especially like atrial fibrillation at a rate of 160, or you may have atrial flutter at a rate of 170 or something like that. You call medical control, and medical control tells you to give cardizem or diltiazem. But before giving this drug, they'll tell you, okay, give them IV calcium before you give this drug, right? Then, does anyone remember what was the rationale for that? Why would you give IV calcium prior to giving diltiazem?
Diltiazem is a calcium channel blocker.
Yes.
So you give the calcium first to make sure, I guess, they have enough calcium so you don't do too much. I don't know.
Oh, well, do too much. Can you be more specific? There is a little bit there. You need to be specific when you say not do too much.
So maybe they're hypocalcemic.
But you don't know that, right? In the setting, in the pre-hospital setting, you're not measuring their blood. You don't know their calcium status, and it's on a physical exam, it will be very hard to say. There is some, things they check, right? Chostextine and some other signs, but in the field, it will be very hard for you to do that. But if you call medical control prior to diltiazem administration, they may tell you give some IV calcium. So what would be rationale for that?
If
You try to like guess, kind of assume that they wouldn't be hypokalemic, so you just give them a little.
So hypokalemia means low potassium level.
No, sorry. So just give them a little more calcium, so you're not bottoming them out, right?
No, bottom them out.
Yeah.
So I'll any other alternate answers? Any other possibilities you guys may think of? So the reason why is this, right? So the diltiazem, right, even though it's a calcium channel blocker, primarily, right, you want to slow down the conduction through the heart to slow the heart rate, but it can also work on the smooth muscle of the arteries. And if diltiazem, which is a calcium channel blocker, works on the smooth muscle of arteries, you can cause some vasodilation. And vasodilation drops blood pressure, right? So vasodilation drops blood pressure. However, if you pre-treat this person with IV calcium, right, there's less chance of them causing profound vasodilation. So then the exertion of this diltiazem hopefully is on the heart, right, on the myocytes to reduce, right, the conduction. So you slow down the heart rate in the setting of AFib or A-flutter without causing profound vasodilation. Make sense? Okay. Any questions about calcium control, right? In terms of low, high calcium, which hormones, and this also, right? IV calcium for diltiazem administration. By the way, when else you give calcium? IV. There's another condition you give calcium for.
Beta blocker overdose.
That's not calcium. That's glucagon.
Oh,
There's one more condition you give calcium IV.
Hyperkalemia.
Hyperkalemia.
Hyperkalemia. And why? So I heard someone was like faint, but why?
Because return back the potential action of the membrane.
And so yes, you're correct. And how does that help me?
By let the potassium and sodium repolarization of the potential membrane come back.
So help me is on the right course. So basically in the myocytes, right? If you have in the setting of hyperkalemia, right? If you have a lot of potassium outside and it trickles in, it may take your resting membrane state, let's say from negative 90 millivolts, and maybe it becomes negative 80 millivolts. And we know our threshold potential, right, is roughly negative 70 millivolts. So if I have a lot of potassium that now trickles in, and I'm now at negative 80 millivolts, the problem is that it's very easy to go to the threshold potential and trigger depolarization to occur, right? So what happens in the setting of hyperkalemia, this is what happens. A lot of potassium comes in. However, if I give you calcium, right, I pre-treat you with calcium, what I can do is I can take your resting state, let's say this state, back higher. Maybe I make it negative 60, right, as my threshold potential. So even though with hyperkalemia, my current state is negative 80, right, I now took my threshold potential to negative 60. So I restored this negative 20 difference. You see how from negative 80 to negative 60 is minus 20? And before it was negative 90 to negative 70, it was also minus 20. So basically by giving you calcium, I restore that difference, right? So that less chance of potassium causing depolarization to occur. So I basically restore this resting threshold by keeping that negative 20 intact, right? So that's how calcium exerts its effects. Right. Any questions about this? All right. So showing you, right, location, right, of the adrenal medulla, right, and all the zones, right, that are here. And the one for this lecture, which is important, is this adrenal medulla, and that's what's making epi, right, which is your endocrine hormone, which is circulates systemically, right. Important to know, right, if you have two kidneys, so you have two adrenal glands, right, the function is the same, right? So they both secrete epi. They're located above the kidney. This is just a close-up view, right? You see how the blood is innervated. The purpose of this is basically to allow the secretions to become systemic. It goes into the aorta, circulates through your body, right? And anywhere that has this receptors for epi, it's going to exert its effects when it becomes systemic. Right? So we talked about all this, right? So here they show you the zones and what is secreted, right, and how it's stimulated. So we know the stimulation comes from your pituitary gland, right, and then, right, that's the response you see, right? So we talked about all of these androgens. We talked about aldosterone, which we'll talk about more in the renal lecture, right? But essentially, it's to prevent losses of sodium and water. So it reabsorbs sodium and water in the kidneys, right? And the final one we're going to talk about, right, is the pineal gland, found in the CNS, central nervous system, right? Here we see a close-up view of it, right? The pineal gland, what's the function, right? So function, right, want to make sure secretion of melatonin, and melatonin, right, maybe you heard, right, you have problems with sleeping, you want to take some melatonin. What does it do? It keeps your circadian rhythm, right? This is the main function. People would be taking it if they have like sleep disturbance or cannot fall asleep, right? And inhibits reproductive functions, protects against damage by free radicals like H2O2, right? Hydrogen peroxide, right? When it dissociates into your radical. So this is some of the functions. Now, in terms of the amounts, right, the ones you have. So all these endocrine hormones are not like unlimited, right? We manufacture them, we store them, and we release them when needed. So when are they released? They release when you have this alarm, fight or flight response. So we see right here, right, sympathetic stimulation, especially from the adrenal medulla. We see the epinephrine, norepinephrine release, right, and all the effects that will cause, right, increase alertness, right, increase circulation, and so forth. But if this is continuous, right, let's say if you are under chronic stress, right, and you have consistent fight or flight response, right, or you're in a condition like, you know, septic shock or any type of shock where your body is consistently fighting, right, against the pathogens, and it's in a constant mode of fight or flight, right? Eventually, you're going to go into the resistance phase where the stimulation of these, right, organs by your anterior pituitary are going to diminish. So less of this is going to be secreted, right? And eventually, you're going to go into the exhaustive phase, right, where you basically do not have any stores. And the infection or the disease process is basically going to overtake you, and you can no longer respond, right? So in the exhaustion phase, hopefully, you are in the hospital and they're providing you medications that will basically maintain these functions, right? So that's what we see, right? So initially, it's alarm phase, then it's resistive phase, followed by exhaustion phase. And here is just here we see an overview of all the endocrine secretions and some of the disorders that you will have. You're not responsible to know all of these, right? And some of these you're going to learn more in your paramedic lectures when you deal with endocrine disorders, right? Like Cushing disease, right? You'll learn about all this syndrome of inappropriate antidiuretic hormone secretions, pheochromocytoma, right? And so forth. But for now, right, what you want to keep in mind, the ones we talked about, right, insulin production. We talked about epinephrine, norepinephrine production specifically. We talked about your cortisol in the stress response as an antidiuretic, as counter-regulatory hormones, right? We talked about antidiuretic hormone secreted specifically, right, from posterior pituitary gland, right? And it was function, right, to reabsorb water. Talked about some of these from the anterior pituitary, right, growth hormone, right, and these, right, the thyroid, we talked about calcitonin and parathyroid hormone for calcium, right, breakdown and increase in the bloodstream. So calcium regulation with calcitonin and parathyroid hormone, right, when you have low calcium storage. And I think insulin we talked about extensively for insulin-dependent diabetics, right, and the DKA formation when they do not get insulin, right? So these all these are the endocrine hormones, right? Here they show you the disorders. Like I said, disorders are going to be more in depth in your pathology lectures from when you do the paramedic portion of it. Right? Any questions about any stuff that we talked about as far as normal secretion, normal regulation?